kind invitation. In particular, Dr. Rekha, for your invitation. Next 15 minutes or so, I will cover the current indication for GLP-1 receptor agonist. We are using this agent from past one and a half decades. So if you go through the history, I think many senior physicians are there. I am also this era. The first era we started during my residency. The target of management of type 2 diabetes was only symptoms and the control of symptoms. This is before UKPDS. Then we entered the second era, where was HbA1c came. This was in 1997 when we were finishing our residency. So main target was a HbA1c and strategy was lower the better. Bring it to 7, 6.5, 6 and other things. Then we had 3 disastrous trial, Accord, Advance and VADT. Then we modified, that was the third era from 2008 onwards. Main target was again HbA1c, but lower the better with lot of caution. That is without hypoglycemia and weight gain. We should achieve target HbA1c without hypoglycemia and weight gain was the strategy in the third era. Now we have entered the new era, what I call it as a fourth era. The main target is cardiorenal events. Yes, diabetes is important. Diabetes is no longer a disease of a sugar. It is a disease of a vascular tree. So our main target is the cardiorenal events. Use glucose lowering agents with a proven benefit, and the drugs what we have got are mainly two. One is GLP receptor agonist and SGLT2 inhibitors. I think all of you are using for more than 1 decade. What is this GLP-1 receptor? GLP-1 is a glucagon-like peptide. It's about 30 amino acid peptide, gets secreted from L cells in the intestine in response to the nutrient entry. This is one of the oldest connection between the pancreas and the gut, because everything existed in the gut in the lower vertebrates. What happens is, on intended nutrient intake, there is release of a GLP and a GIP from the intestinal L cells. So on release, it does two functions. One, it stimulates the beta cell to produce the appropriate insulin to control the postprandial glucose, and also to suppresses the alpha cell so that glucagon production comes down, and it reduces the hepatic glucose output, and overall there is improvement in the postprandial glucose. But the action of this GLP-1 is very short-lived. It is few minutes, because it is acted upon by one enzyme known as a DPP4 enzyme, which converts into inactive GLP-1 and inactive GIP. And see, this degradation of a DPP4 enzyme and for a short minute brought an oral medications known as DPP4 inhibitors, which we are using. To prolong the action of GLP-1, native GLP-1, we need a longer half-life, not few minutes. We require a day, sometimes even a week. It can come even for a month. So we have to alter the amino acid chain so that it's not degraded by the DPP4. Hence the need for GLP-1 analogs came. That's what we are having from past 2 decades. These are the most important. This is the native GLP-1. Liraglutide is almost 97% homology to the native GLP-1. The homology is very important, because if it differs in more amino acid, the antibody production is more. And dulaglutide is once a weekly. Then exenatide was first one to came, had only a 40%, 47% homology. It's discontinued. Even lexisnide has been discontinued. Albiglutide is also been discontinued. What's the action of this GLP-1? On release or on using pharmacologically, it acts on the hypothalamus in the brain, reduces the food intake, and also it protects the brain, and also it reduces the reward behavior. On pancreas, it stimulates the beta cell on nutrient mediated insulin. Means if you take a n number of amount, only n number of insulin gets released, and also it reduces the glucagon secretion, shown to reduce the beta cell apoptosis, hence maintains the beta cell mass. It delays the gastric emptying. And do you know what is the contribution of the gastric emptying for the postprandial glucose? Any postgraduates? It's about 30%. By delaying the gastric emptying, you can reduce the postprandial glucose by 30%. It does act on the adipose tissue, reduces the inflammation. On the muscles, it improves the insulin sensitivity. It produces natriuresis and diuresis, hence it got a beneficiary effect on the kidney. It has effect on the platelets, endothelium, heart and the liver. Overall, this has got a beneficial effect. That's why it got recommended for use in diabetes. So the most important indication came for a diabetes. And there are two types of a GLP-1 receptor analogs we have got. One is a short acting, needs to be given daily. Other one is a long acting, needs to be given weekly. So short acting have got a major reduction with the postprandial glucose, whereas the fasting glucose reduction is less. With the long acting, there is strong reduction of both fasting and the postprandial, and also needs to be given once weekly when it comes to the dulaglutide, and your short acting ones like exenatide needs to be given twice daily, whereas liraglutide can be given once daily. Overall, what is the importance is delays the gastric emptying, reduces the weight, and also reduces the cholesterol, and the HbA1c reduction is to the tune of 1.5 to 2%, which is seen with older SUs and the insulin. So we know that all of us were familiar with this picture of DiFranzo in 2009, ominous octet in the pathophysiology of type 2 diabetes. Roughly these are 8 things are responsible for pathophysiology of a type 2 diabetes, and if you look into GLP-1 receptor agonist, it addresses 6 out of the 8. Almost 6 out of the 8 pathophysiologies of type 2 diabetes gets addressed with GLP-1 receptor agonist. So this has gone to a rigorous clinical trial, whether it's a liraglutide with the duration, whether dulaglutide with the award, semaglutide with the sustain. All these trials have consistently has shown that more than 1 to 1.4% reduction in the HbA1c when used in the clinical trial. This reduction in the HbA1c comes with even reduction in the body weight to the tune of 2 to 5 kgs, depends on the baseline weight. If baseline weight is more weight loss happens. In a leaner person, the weight loss is less. And more importantly, the reduction in the weight happens mainly by reducing the visceral fat, which is metabolically inert and more responsible for cardiometabolic problems. Then the question comes, yes, it reduces the HbA1c, it reduces the weight, it reduces the visceral fat. What is the risk of a hypoglycemia? Risk of hypoglycemia is almost similar to the placebo. This is a comparison study where they have compared with the glimepiride, which is one of the standard drugs I think used across the globe. Compared to glimepiride, you can see that it is almost 7 times less, and it is equivalent to the placebo. You give a placebo, you give GLP-1 receptor agonist, the hypoglycemia risk is almost similar. Then came the next indication, that is a cardiovascular disease. We know that 2/3 to 3/4 of patients with type 2 diabetes die because of a heart or a heart-related events. So preventing cardiovascular outcomes is one of the most important management in the type 2 diabetes, and it has been found that it improves natriuresis and diuresis, reduces inflammation, reduces smooth muscle proliferation and a platelet aggregation, important contributor for atherosclerosis, improves the blood flow, plaque stability, improves the vasodilatation and the endothelial function. All these things are going to improve the cardiovascular function and also prevents the atherosclerosis. This is the one drug which reduces atherosclerosis and prevents the cardiovascular disease. So this has been studied in all the CVOT outcome trial, whether it's liraglutide with the leader, semaglutide with the sustain, or a dulaglutide with the revend, or a albiglutide which has been discontinued with the harmony. What has been shown consistently is 14% reduction in the 3-point MACE, 17% reduction in the stroke, and 10% reduction in the MI. These are the benefits seen on and above reduction in the HbA1c, weight, and also reduction in the visceral fat. That's why they have been approved in patients with type 2 diabetes with a high risk for atherosclerotic cardiovascular disease, both liraglutide, dulaglutide, and semaglutide. That's the injectable. We have got oral one that's not been approved, whereas injectable is one approved for the use in patients with type 2 diabetes with high risk of ASCVD. Then what's next? I think the next problem what we have in patients with type 2 diabetes is a chronic kidney disease. It has been found that physiologically this GLP-1 has got some direct effects and an indirect effect. The indirect effect is it reduces the glucose level, and we know that the moment glucose level comes down, the microvascular complications comes down. Hence the glycemic control reduces the microvascular complication, that's nephropathy. Improvement in the blood pressure improves the kidney function. Even a weight reduction helps in the kidney protection, and also it produces natriuresis and reduces the inflammation. All these things are renoprotective, And meta-analysis of all the studies has shown that the composite kidney outcome, whether it comes to the albuminuria or a creatinine doubling, all these things have shown that use of GLP-1 receptor agonist helps to reduce renal events. And the one latest being the injectable semaglutide. This got published July 11th in NEJM. Even this showed it reduces clinically important kidney outcomes and a death from cardiovascular causes in patients with type 2 diabetes and a chronic kidney disease. So these are the agents which are approved to use: liraglutide, semaglutide, and a dulaglutide in the patients with type 2 diabetes and a CKD. So whenever the patient with type 2 diabetes has a CKD, SGLT2 inhibitors remains as a first choice. Somebody who can't take or who can't tolerate SGLT inhibitor or can't achieve the target with SGLT inhibitor, you can use GLP-1 receptor agonist like liraglutide, semaglutide, and a dulaglutide. Then the major problem what the world facing, including India, is obesity. What was observed across all the trial, whether it's for leader, sustain, excel for the type 2 diabetes, consistent weight reduction with these agents to the tune of 2 to 5 kgs in comparison to the comparator or a placebo, and they found that this drug has got a potential to reduce weight. So possibly it is both central and also it reduces the stomach fullness comes, gastric emptying gets delayed, person can't take much food, that also helps in the weight reduction. There are many agents which are approved for the weight reduction, many are not successful. Probably in the past 1 decade, this class of drugs have stood the time. In fact, all anti-obesity drugs, I think all of us, we know that we have used only for a short period, then it's not successful. I think 3 drugs have been approved for use in obesity. One is liraglutide in 2014 as a Saxenda, that's 3 milligrams. What we are using is 0.6, 1.2, and a 1.8 for type 2 diabetes. For obesity, it is 3 milligram. Then comes the semaglutide, got approved in 2021, and tirzepatide, that's in combination with one more gut peptide. It's approved last year, and the demand is so much, they have delayed the launch of this agent in India by 1 year. So these are the traditional indications, but there are more extended indications for GLP receptor agonist. One such is a NASH. I think if I see all my type 2 diabetes patients coming with ultrasound abdomen, more than 90% have got a ultrasound report of a NASH or a fatty liver. This drug has shown to improve the NASH. It has been in the clinical trials, and it has shown to resolution of a NASH without worsening fibrosis and decreases the rate of a fibrosis progression, both liraglutide and a semaglutide. The other one, I think all of us face in the future, and many of our relatives are having in the family, is Alzheimer's disease. This Alzheimer's disease being addressed by this GLP-1 receptor agonist, it has got a multiple actions at brain, reduces the inflammation. Atherosclerosis is one of the contributors for Alzheimer's, increases the blood flow, reduces the oxidative stress, reduces neuroinflammation, and also protects the neuron. And this has been shown with the clinical trials with GLP-1 receptor agonist, reducing neuroinflammation, cerebral blood glucose improvement in the blood-brain integrity, synaptic viability, reduction in the amyloid, and also phospho-tau. These are the 2 ongoing trial in a phase 3. Means once they have entered the phase 3, means only thing is they have to show a benefit in the patient. Safety things are most of the time over. Only the benefit, it has to be seen in the clinical practice. Probably in 4 years from now, we'll be using this agent in the Alzheimer's disease. In the past 100 years, other than insulin, we didn't have any medication for a type 1 diabetes. There are promising trials. One such trial known as adjunct trial with use of GLP-1 receptor agonist in type 1 diabetes has been done. It has been shown in a 1-year treatment period, weight loss, improved glycemic control, reduction in the insulin dose, and also reduced glucose variability, what that LSM was speaking earlier. So lot of everything benefit I have spoken, nothing comes without a concerns. The concerns with GLP receptor agonist is most frequently reported side effect is a gastrointestinal side effects, nausea, fullness, and vomiting in some patients with the diarrhea. These are all mild to moderate. Start with a smaller dosage, hike up slowly. So over a period of months, patient tolerates the drug. Previously, there was link of GLP-1 receptor agonist with a pancreatitis and a pancreatic cancer that has been laid to the rest. However, recent meta-analysis and all doesn't suggest the same. There is some amount of a sludge formation of a gallbladder. This is because of the delayed gastric emptying has been noticed in recent trial. What is the perspective? I think what has been caught the importance is weight loss with these agents with one more peptide, either with a glucagon or a GIP. The profound weight loss seen with this agent to the tune of what we achieved with bariatric surgery, to 20 to 25% of the weight loss with these agents. Probably this is the future of obesity treatment in next decade. To conclude, GLP receptor agonists are a game changer in type 2 diabetes, to some extent even in obesity. GLP receptor agonists represent an important drug class for the treatment of type 2 diabetes and offers the market cardio, renal and metabolic benefits, protects heart, protects kidney, improves HbA1c and also reduces weight. Ongoing studies will explore the benefit of this agent for a NASH, neurodegenerative disease like Alzheimer's and a type 1 diabetes. Emerging dual agonist, GLP-1 with the other gut peptides, probably going to achieve much more glycemic control and also weight loss in the future. I think this is my last slide. Thank you for your patient hearing.
Thank you, Dr. Vagish.